So I will be focusing more on the clinical side, and Joel will be focusing more on the basic science side. So for my piece, the overview of what we'll talk about, very briefly, I'll talk about what a prion disease is, although you're going to hear about transformers and a much more accurate depiction of prion disease from Joel later on. You are doing the transformer thing, right? Awesome. Okay. And I'll talk a little bit about the demographics of prion disease, the rarity of it, how frequent it is. And then we're going to spend a lot of time on the diagnostic process of prion disease. And then we'll talk about why so many people have so many different experiences. If you're in the sporadic workshop, you heard that there are a lot of different experiences. You had people who passed away within a week or two of having symptoms to 3 years after symptoms. Why is there so much variability? And then this is very similar to last year, although there are a lot of newer people here. There is some newer stuff, so it won't be completely reiterative of last time. So first off, what is a prion? A prion stands for a proteinaceous, an infectious particle. That means it's only comprised of a protein, and it can be transmitted under very specific circumstances. We all make normal prion proteins. That stands for, in our field, PRPC, which stands for cellular prion protein. So if you hear that, think about the normal prion that we all make. You can see its 3D structure has a lot of these kind of red coils, something that we call alpha helices. It's primarily made in our brain and in our stomach, and it has a variety of different useful functions in our body, such as acting as a messenger, maybe help with brain cell housekeeping functions, but it's supposed to be there and it's beneficial. However, the problem is when it changes its shape. So it can be the same protein, but it can be misfolded in a different shape, and that makes it a pathologic form of the prion protein, sometimes referred to as a prion or PRPSC, which stands for the scrapie protein. Scrapie is a prion disease of sheep and goat. So you'll see that in this abnormal disease-associated form of prion proteins that you still have some of that red curlicule type thing, but you'll see that you have a lot of these blue lines that are in parallel to one another. That's called a beta-pleated sheet. And that beta-pleated sheet is really what makes it toxic to brain cells, but also easily transmissible. And when I say transmissible, most of the time you're referring to transmissible within an individual. So again, we all make the normal prion protein, the yellow dots. It comes into contact with the abnormal form, the blue dots, and those blue dots turn the yellow dots into itself, kind of like the bad kids in the schoolyard converting the good kids into the gang. You get this kind of exponential rise of the abnormal prion protein, and that's what we mean by propagation or transmission within an individual. And that's somewhat unique to prion disease, but we also know that this also happens in other progressive brain diseases that are due to protein misfolding. And that includes things like Alzheimer's disease, Parkinson's disease, Lou Gehrig's disease. They all kind of had this fundamental property where that abnormal form of a normal protein that we make can propagate within one's brain and cause problems. So there are a variety of different causes of prion disease. If you're in the last session, this is not a why, this is a how it happens in people. Most of the cases in our country, 85 to 90% of cases, are due to what we call sporadic prion disease. And what that means mostly is that probably that normal prion protein that we all make spontaneously changes its shape into the abnormal form causing disease. In our field, again, we have a lot of lingo, so we have a lot of kind of fancy names. So there are some named sporadic prion disease, things like sporadic CJD, variable protease-sensitive prionopathy, and sporadic fatal insomnia. These are just ways that scientists kind of subcategorize diseases, but they're all sporadic forms of prion disease, meaning that they just spontaneously develop in an individual. More likely to happen as people get older, but as you heard in the last session, sometimes it happens in younger people as well. The next largest cause of prion disease in humans are genetic, and this is due to a genetic mutation of the prion protein gene. Again, we all have that gene. We all make normal prion proteins, but in people that have a genetic mutation of the prion protein gene, it starts to make a slightly abnormal form of the prion that makes it more likely to misfold into that disease-associated form. And there's about 50 to 60 different mutations of the prion protein gene that can cause the disease. And they also have different names as well, such as genetic CJD, Gershman-Straussler-Schenker disease, or fatal familial insomnia. These different names basically denote that they look different underneath the microscope. They're associated with different mutations of the prion protein gene, and they also can have quite varied clinical symptoms as well. Fortunately, the ones that we hear the most about in the media are by far the least common cause of prion disease, and these are the transmissible forms or the acquired forms. This includes things like Kuru, which was kind of when we first learned about prion disease in a tribe in Papua New Guinea that engaged in a mortual practice of consuming their loved ones following their death, and it was unfortunately transmitting a CJD-type illness amongst the tribe. Iatrogenic CJD is medically transmitted CJD through very specific medical procedures, usually reusing material from a cadaver, a person who passed from CJD or had infection of CJD that then was reused in a healthy individual, and that's how the disease was transmitted. And then variant CJD, which is what we call CJD in a human due to eating meat contaminated with bovine spongiform encephalopathy or mad cow disease. Again, fortunately, these are by far the least common. Hopefully, this will somewhat validate most of your all's experience with your loved ones. This was a study that was sponsored by Ionis, in which we looked at medical claims data, looking at basically diagnosis of people with CJD across the U.S., looking at medical claims. And what you'll see here is that the median time from the first symptom of the illness until someone passed the disease was about 6 months. The first time, because as you know, in your diagnostic process, you usually don't get diagnosed with CJD out of the gate. You have at least one other diagnosis or multiple diagnoses usually. So from that time until someone passes, it's about 3 months. So you can see there's about a 3-month span of time before someone even gets a wrong diagnosis before the right one. And then from the time of first diagnosis of CJD to death is a median of about 1 month. So pretty dire, but that's where we are. This is another way of looking at it. Again, if you look at the very last section, first CJD diagnosis to death, 67% of people, that's under 2 months. And I think that's what most people's experience has been. And we'll talk about why that's the case. There are some things I think that we can change to improve that, but there are some important limitations that we're going to come across that may not be modifiable to help us increase the earlier diagnosis, and I'll focus on some of that as well. Moving on to epidemiology. Epidemiology is the study of how frequently an illness affects a certain population. Everyone has heard the 1 in a million number. That's a public health statistic that states the number of new cases of prion disease that happen every year across the entire population. However, it's important to know that CJD doesn't affect all age ranges equally. So if we look at the average, or across all ages, the incidence is about 1 to 2 per million per year. And this is equal across no matter what country you look at. If you have a better surveillance system, you might get closer to 2 per million per year, but it's always within that 1 to 2 million people per year. However, if you look at people that are older, so people age 65 and older, that incidence is about 4 to 7 per million per year. And that's because CJD preferentially affects the mid to older population. However, if you look at the younger population, those under the age of 65, that incidence is about cut in half to about 0.5 per million per year. So again, it's a little misleading to use the 1 per million per year because, infants don't get CJD, kids don't get CJD. So the number that we like to use is lifetime frequency. And this is also the number of deaths that happen in the US every year due to CJD. It's about 1 in 6,000 deaths. That's a lifetime frequency. So not as rare as probably most people think. And that's probably because we usually talk about this in incidents and probably misportray how frequently it is. So another way of looking at this, and I apologize to any Cleveland Browns fans, but CJD is essentially as rare as a Browns touchdown. I'm from Cleveland, but I'm happily not a Browns fan. I feel sorry for those people. And what I mean by this is that it's not expected, but it happens, right? Just like a Cleveland Browns touchdown. Not expected, but it happens. And if we look at a stadium, so the Cleveland Browns stadium has about 70,000 people. If we go back to that last statistic, we would expect about 12 people in that stadium, if it's sold out, which it never is, will get prion disease at some point, okay? So again, this is not a common illness, but you will come across people that have also had an experience with this. So sometimes people refer to this as clusters. So clusters just means that there's a number of cases of prion disease, and usually either a geographic common place, like around a city or a county, or temporally in the same time. So many different cases happen during this time period. So the way that we investigate clusters, and you're going to hear about this on Sunday from Dr. Maddox as well, who works at the CDC, it's primarily investigated by CDC and local health departments with our assistance. And there's a variety of different steps that we take to investigate the cluster. First, we have to verify that these suspected cases of prion disease wind up actually being prion disease. You'd be surprised. In almost every single cluster that we investigate, at least one wind up not being prion disease. And because we're worried about a rare disease, having 1 or 2 cases in that cluster that aren't even the disease can be quite significant, actually. We have to verify the type of prion disease. So again, when we're investigating clusters, our primary concern is that there's some type of common risk factor. So if we see that these are 2 cases of genetic CJD that may be even related to one another, that's not really a concern for an acquired risk factor or common exposure. We would expect that with genetic CJD. And then we also have to verify that the numbers being investigated are higher than what is expected. So if we take the case of Ohio, which has about 11 million people, at any one time, we would expect a range of 11 to 22 new cases of prion disease at any one time. That's quite a wide range. So a lot of these clusters, although there are clusters, they're actually within the range of what we would expect for that population over that period of time. And then, of course, we have to verify the likelihood of a common exposure. Prion disease is not easy to transmit. It basically takes brain-to-brain contact or reusing brain elements in another healthy individual, taking brain-infected tissue and injecting it into someone, or orally consuming brain tissue. And that usually does not happen in most healthcare settings. There are some instances in which that could happen, like neurosurgical instrumentation, but it's pretty uncommon. And then one of the things that we know about prion disease is, at least in the acquired forms, we have something called an incubation period, which is the time from someone being exposed to prion to the time that they develop symptoms themselves. And we know that for prion disease, that incubation period is measured in years to decades, not in days to weeks. So the old name for these illnesses, before we knew what they were caused by, were slow viral illnesses because of that. So again, we would expect clusters, and keep in mind that there's a lot of randomness to disease, and that randomness can play funny numbers when you look at statistics. So Bob Will, who many of you may remember, had this very apt analogy of taking a bag of rice and throwing the rice on the floor. You'll see that those pieces of rice will cluster, but that doesn't mean that it wasn't a random event. Randomness also clusters, so you have to take that into consideration. So the rice bag of my life, and these are all instances in which I've come into contact with prion disease that have nothing related to me being in the field of prion disease. I've seen 5 cases of prion disease within my small community of about 30,000 people in the last 10 years. That's expected. My research nurse was in the son's wedding of one of them, who lived about 0.5 miles down the street from me, who also happened to be a neurologist, who also has since diagnosed 5 cases of CJD himself. My daughter's dentist brother-in-law had CJD, and my social worker actually had went to him for physical therapy. He was a physical therapist. I went to a friend's funeral, and the grandmother of one of his friends had recently died of CJD, had no idea that I was in the field, had recently got the autopsy report, and I was able to go over that with her. That was quite random. I was seeing a patient for Alzheimer's disease for a very long time in my clinic, and my colleague came up to me one day and said, "I think the daughter of one of your patients has CJD." And she did. And this actually was also a friend of Katie's husband, who works at the Prion Center as well. Former departmental chairman that I used to work at in Cleveland Clinics, mother died of CJD. And very weird, a beloved teacher in my daughter's school community died of CJD. And this was an individual who used to take his students to Italy every year. And my daughter was leaving for that trip the day after I diagnosed him. So very weird. So let's transition a little bit to how is prion disease diagnosed and why does it take so long? So the diagnostic process is not unique to medicine. It's very common in things like technology and anything that requires mechanics. My dad was a mechanic. He said that we had it easy. We only had 2 models, male and female. He has Mazda, Ford, Chevy. So in a way, I guess medicine does have it easier, but we go through the same diagnostic processes. So the way medicine usually works is you can't do every single test in everyone. You have to kind of fine-tune the right test for the right individual based off of the probability that they have an illness. So the way we do that in medicine is something called a syndrome. And a syndrome is a collection of signs and symptoms that help point to the underlying cause of a problem. So recognizing syndromes can help a clinician know what to do next and what tests to order. So a perfect example of this is in technology. If your computer doesn't work, you go through a variety of different tests, right? So is your monitor plugged in? Does it work? Does your mouse and keyboard, are they plugged in? Do they work? And then finally, is your hard drive crashed or is it a software issue? We do the same thing in medicine. So if you ever have someone who has chest pain that shows up in an emergency room, you start looking for a collection of symptoms. Do they have chest pain, shortness of breath? Does the pain go down their arm? These are syndromes that help identify the likelihood that maybe someone has a heart attack, and then you order the correct test. Same thing. It's not unique to medicine. So what about prion disease? How does this work? And I'm just going to take one example of what some patients may present and how that diagnostic process would go. So say someone presents to a doctor with confusion. They have memory problems. They maybe are getting lost. So the doctor will ask them questions. They'll do an exam. They may have a list of possible diagnoses. In medicine, we call this a differential diagnosis. Things like Alzheimer's disease, vitamin deficiencies, thyroid problems, depression. In medicine, we're always going to prioritize things that are treated or treatable because we don't want to miss them, right? We don't want to miss treatable things. We don't want to miss untreatable things too, but of course, if we miss treatable things, it has a lot more consequence to people. So looking at that list of possible diagnoses, it will result in a variety of other diagnostic tests that we might order. We might order neuropsychological testing, which is in-depth paper and pencil testing of someone's memory. We might do blood tests to look for things like vitamin deficiencies or thyroid problems. We may do brain imaging to look for things like stroke or tumors. So then you do that, the patient comes back after all that's been done, and now they say, well, not only do I have memory problems, which by the way are worse since last time we saw you, but now I'm falling more. Well, that's kind of a different symptom cluster, right? It's a different syndrome. So now the list of possible causes is different. So now it's maybe someone has blood vessel disease or vascular disease of the brain. Maybe they have an infection of their brain or inflammation of their brain, something we heard about a lot in the last session, something called paraneoplastic syndrome or autoimmune encephalopathy. So that's going to result in a cascade of a variety of other diagnostic tests, things like more blood tests, brain MRIs, maybe even a lumbar puncture or a spinal tap. And then that, again, we're always going to rule out the list of potential causes and look for results that suggest a cause. So that takes time. And the key thing here is time is really important for diagnosis. And in fact, a common thing that we like to say a lot is sometimes time is actually the best diagnostic tool we have. And families don't like to hear that, of course, because time is valuable. But sometimes we don't know what test to order unless we see kind of symptoms, how they evolve. So some typical symptoms of human prion disease, it's going to be varied in everyone, but these are the most common symptoms. It can be cognitive impairment, memory problems, problem coming up with words, problems with their walking or gait, abnormal movements, Parkinson's-like symptoms or jerky-like movements. Sometimes people have visual disturbances. They can't see like they used to, so that results in them tripping over things. They may have muscle weakness or a variety of different psychiatric symptoms, some things like mood and anxiety disorder, sleep disturbances. What's important to remember, though, is that we look for a clinical syndrome of CJD, which generally in the textbooks means someone has memory problems, problems with their balance and walking, and something called myoclonus, which is like a jerky-like movement. But almost no one presents to the doctor that way. So if you look how people present initially to doctors, most people will present with isolated cognitive symptoms, and they may look like maybe early symptoms of Alzheimer's disease. 17% will have a variety of other symptoms that might not even be suggestive of neurologic illness. 15% could present with nonspecific psychiatric symptoms, which again, you would hope that most people wouldn't assume or think of CJD as the first thing, because that's a highly treatable illness in most people. Only about 13% of people present with kind of that classic syndrome of CJD out of the gate. So what that means is only about 13% of people does the clinician have the opportunity to order the right tests out of the gate. All right. That means the other people are either going to require other diagnostic tests that may signal that this patient might have CJD, or they're going to have to require symptom evolution over time so that the doctor knows what to order. So let's talk about some prion disease diagnostic tests. We have something called the electroencephalogram that looks at brain waves, kind of like an EKG for your brain. We have the brain MRI that looks at the structure of the brain and any abnormalities in there. And then we can take spinal fluid using a spinal tap. EEGs, or electroencephalogram, are very helpful nowadays for ruling out other causes, especially things like seizure disorders. They can occasionally be suggestive of CJD, but usually they won't be. The brain MRI is present in about 95% of all cases of sporadic CJD. It drastically narrows down the possibilities of what could it be. And in some cases, especially cases where that full diagnostic syndrome isn't present yet, it may be the first thing that signals to the doctor that, hey, maybe this is CJD because their MRI kind of looks like it, even though they don't. Then the spinal tap, in my opinion, is most helpful for ruling out other causes, especially treatable causes of disease like autoimmune encephalopathies and infections. There are some markers that we use to suggest CJD, and then there's one marker that we call RT-QuIC that is almost only seen in CJD, and I'll talk about them in detail. So some of the terms that you may hear about over the weekend are things like sensitivity and specificity. In general terms, sensitivity is how well your test finds the disease that you're actually looking for. So it's quite broad and all-inclusive, whereas specificity is how well does the test only find what you're looking for. So it's very narrow or specific. So if we look at these three diagnostic tests, EEG is not very sensitive. It won't be suggestive in most cases, but if you do see it, it's fairly specific. There's not a whole lot of other things that it could be. The brain MRI is very sensitive. Again, 95% of cases will have an MRI suggestive of prion disease. And in the right hands, it can be pretty specific. However, in some cases, it can mimic autoimmune encephalopathy, which of course can be treatable. So most people want to treat that as well. And then the spinal fluid tests are generally very sensitive. Some tests are very specific, such as RT-QuIC, and then some are not specific at all, like our beloved 1433. As far as expertise, EEG requires some local expertise. Most hospital systems will have someone that can read EEGs. They're generally not hard to come by. Brain MRIs, almost everyone will have an expertise to look at them. However, they may not have the degree of complexity to recognize a case of CJD, although I would argue they should at this point. It's very well known what CJD looks like on a brain MRI. And then for the spinal tap, the doctor, of course, has to know what to order. They have to have that clinical suspicion. And then there's only 2 labs in the country that do RT-QuIC right now. So at the Prion Center, we do 3 diagnostic tests. 2 of them are markers of brain cell injury. That's 1433 and total tau. They're useful in that they can maybe give you a suggestion that that's what's going on, but they're not very specific. They can be elevated in a variety of other conditions. Then there's RT-QuIC, which detects the abnormal prion protein itself, so it's very specific, with a likelihood of about 99%. RT-QuIC stands for real-time quaking-induced conversion. It takes advantage of that prion paradigm. We take a 96-well plate. The substrate for the reaction is normal, recombinant or lab-created prion protein. We add the sample, which presumably has the abnormal form in it, and then something called thioflavin T, which will bind to any fibrils that form. We put it in, for lack of a better term, a shake and bake oven for about 60 hours. That kinetic energy will, if there's prion protein present, convert the normal prion protein into itself, and it will start amplifying to the degree that we can actually detect it through that phosphorescent dye. Again, we wouldn't expect that really to be positive in anything but prion disease. So the main limitations for diagnosing prion disease, as we've heard in the last session, there's a lot of variability within prion disease. Depending on how the person presents, it may be easier or harder to know whether or not to order those prion-specific tests. At least some basic knowledge of prion disease has to be required. You have to know that it at least exists. And CJD needs to be on the list of possible causes to get the test, but it may not be high because, again, we're ruling out treatable causes as well. And then we talked about this at the last session. A lot of it is dependent on the clinician having the confidence of giving the diagnosis. Many times, a physician may very well know or highly suspect that someone has CJD, but they don't want to tell the family until they're absolutely sure. And this is the double-edged sword of RT-QuIC, which really helps because it's so specific for the disease that we see that clinicians are much more likely to give a diagnosis of CJD when it's positive, but when it's negative, they really feel uncomfortable. They want to keep reordering the test, make it positive, but there are some cases of CJD that will never have a positive RT-QuIC. So it's a double-edged sword. Last time, we talked about, well, what about artificial intelligence? That's about all you hear about on the news nowadays. So we did this exercise last time. How can we improve the diagnosis of CJD? AI has to be helpful to some extent. So this is version 2 of that. I used the same exact case as last time. 79-year-old woman who initially started having changes of her speech, would frequently drop things starting about 4 months ago. And what's the possible list of diagnoses and the order of likely diagnosis? And this is a different list from last time. ALS is now at the top. I don't know if I agree with that. But you see a lot of other primarily progressive brain diseases as well. Quite a varied list. And then I ordered or asked it to have recommended workup, and it did a pretty good job, actually. And we would have gotten the correct diagnostic test done by its recommendation. And then I put in what the results were for this particular patient, says what's the most likely diagnosis, and it says sporadic CJD. So this was better than last time. So let's compare what happened from last time to this time. So the problems last time, if you weren't here, is it initially suggested more than $1 million workup, $1 billion workup. It basically said order everything. There was no mention of RT Quick. And the patient was diagnosed in the same time frame as her human doctors diagnosed her. But we had come away with that there's probably potential for AI to properly at least diagnose the MRI for neuroradiologists that might not recognize it, and that may result in an earlier diagnosis. So this year, some of the initial workup was unnecessary, but not nearly as bad as it was last year. But there was a lot of the clinician may want to consider this or that. So a little bit loosey-goosey. But again, it's mainly as a guide. Again, it was diagnosed the same time point that her doctors diagnosed her. Here's the big problem, my point of view, is it assumes a sporadic etiology. That can be dangerous, right? If you're just going by this, because it's not going to tell the family that it could possibly be a genetic diagnosis or an acquired diagnosis. So potential here, again, I think there's a lot of possibility here for assistance with MRI. I think it was much more practical as a brainstorm or assistant tool this time around as opposed to last year. And one thing that I was very surprised about, and I didn't show this, but I asked, well, what should I do for this patient? And it did an outstanding job of management approaches. Number one and number two. Number one was referred to the CJD Foundation. Number two was referral to the Prion Center. Number three was consider hospice. So right along to what we would say, right, when someone's diagnosed. I don't remember what it did last time, probably because it was so horrendous. All right. So I know I'm over time. I apologize. This shouldn't take too much time, but I just want to end on why is there so much clinical variability in prion disease. First off, there's a lot of different variability in the pathology of prion disease. And at the Prion Center, we do a variety of different diagnoses. We look at the brain tissue underneath the microscope. We do something called a Western blot, what looks at the shape and size of the prion protein. And then we do genetic testing of the prion protein for two reasons. One is to make sure it's not a genetic mutation. And then two, there's a position of the prion protein gene at codon 129 that has a tremendous impact on what the disease looks like. So there are about 6 different molecular subtypes of sporadic CJD. Sorry. And the way we break them down is, again, that position at 129. We all have 3 different flavors. You can either be MM, MV, or VV. All of us are that. It's not a mutation, but it has a great degree of influence on if someone were to get CJD, what it would look like. That Western blot usually results in 2 prion protein types. It can be type 1 or type 2. And then the molecular subtype is created by matching that position at 129 to the prion protein type. So you get MM1, MM2, VV2, VV1. And that combination looks very different underneath the microscope, but also has a tremendous influence on the clinical symptoms, the duration of the illness. You can see some of the clinical features. MM2 and MV2 tend to have a much longer duration, like a year or 2 or maybe even 3 years, where MMM is extremely quick, often misdiagnosed as stroke, actually, because it's so quick. So that's one, probably the primary reason for variability in prion disease. There are other things too, like for genetic prion disease, I said there are a lot of different genetic mutations, over 50. As you can probably imagine, the illness looks different depending on what mutation it is. Variant CJD, the kind due to eating meat contaminated with mad cow disease, looks quite different from other prion diseases. It tends to affect younger people and tends to present more with psychiatric or sensory symptoms. And then, of course, there's the possibility of new prion diseases, which you'll hear about more on Sunday. The thing that we're worried about the most in the U.S. is this prion disease of deer and elk called chronic wasting disease that could possibly transmit to humans. We have no idea what that would look like. But assuming that it follows something like variant CJD, we would assume it would have different clinical features to some extent from what we would typically see. And then there are a lot of other, I could do a whole 20-minute talk on why there's variability, but the last thing I wanted to talk about is age. And we see this also in other progressive brain illnesses like Alzheimer's disease. people with young onset Alzheimer's under the age of 65 tend to present more with psychiatric symptoms, whereas people that are older tend to have more memory symptoms. So the same thing happens actually with younger people with sporadic disease. Those that are under the age of 50 tend to have a lot more affective illness. Affective illness means things like mood and anxiety. So although you see this a lot in variant CJD, you see it in just young people in general. And it's the same thing with sensory symptoms, things like pins and needles, what we call paresthesias or numbness and tingling. We see that a lot in variant CJD, but we also see it very commonly in people that are just younger with sporadic CJD. So there are a lot of different things that go into variability. The problem is this is a rare disease. So when you have a rare disease and a lot of variability, it's across the board and can be very difficult to diagnose. So with that, I just want to thank you again for coming, and I'm going to turn it over to Joel to talk about the basic science aspects of prion disease.